if there are more than two members of the family who have history of heart disease, my trigger for CT angio as a screening device is much lower. That I would say, at a certain point where it may be around 25, 30, 35 years of age, that people who fit the predictive model should be screened because of the fact of two facts. One, if you know at that age, so like I said, 30 plus minus 5, depending on the propensity. If you know at that time that there is no evidence of any atherosclerotic disease, and coupled with the other screening devices that we talked about for endothelial dysfunction, then you know that these people, in spite of their inherent risk factors, are still okay. That doesn't mean they're going to stay okay forever, but the fact is that it gives you a 5-year window. On the other hand, if you see that there is beginning, then of course that blinking red light becomes a huge flashlight to say you are already in trouble. You need to now see it black and white. See, one of the things that's very interesting in the CT angio is that when you see a visual, you have the doctor telling you and showing you the visual, you take something much more seriously than you would if you were talking theory. Because as you know, when you're talking to patients, their attention is only 30 to 50%. I mean, they're scared. They can't pay attention to everything. There are some technical words which will go over their head. So a visual has a very big impact. So if you see early detection of atherosclerotic started, it gives you the best advantage to keep these people free of disease as we move forward. Second, if it has gone up to already significant over 50%, 60%, there is still, if we make an extra effort, there is a possibility of some reversal. If not reversal, you can at least delay the progression. If that happens, you've still done a lot of service. Of course, if it shows some critical lesions, then you've already done a service to the individual, because today, interventional cardiology has a very, very important role to play. But then before that, we have many devices of screening which have come to fore. So what happens, I'll tell you, this is the most frequent thing that happens to people who go for CT scan. So a fair number will have no disease, which is fine. Congratulate them, tell them you live your life, but don't go abuse it. Second is the fact that the early detection, you want to pay attention to their biochemical makeup, their stress, all that other stuff we talked about, exercise, all this stuff. Now that the third category, which has 50, 60, 70%, and you know that CT angio is not a 100% accurate prediction of the level of obstruction, then of course, the best way to follow them, if you see it's 50, 60%, is to do a thallium scan. Because the thallium scan will tell you if there is any functional deficit. If there is a functional deficit, you know that you need to go for regular catheter-based angiography and do whatever intervention you have to do if it is serious. Second is the point that it gives you the comfort that it is not critical today, and you can follow them maybe a year later, but it also gives you a baseline. So you can follow them with stress echoes, treadmills, whatever you may like, depending on what you find on the thallium scan. And then be able to say, okay, if at the slightest symptom, I will repeat do the angiography, or if I see any changes in the ECG in the future, I will change it. I will go towards interventional techniques. And if there is a frequent event, if there is already a 50%, I would repeat these tests every 1 year at least, if not more frequent, depending on. But the moment it crosses 60%, your CT score, and there is calcification, all that, I have a very low trigger for going for catheter-based angiography. So I think if you do all this, we know that the safety of all these procedures is very, very well established. So if you take the caution, you know that they don't have any kidney problems, you know that they don't have any massive allergy to iodine, then these procedures are actually, I have not seen a single person, I'm sure it's reported somewhere, having suffered any major adverse event from a CT angio. So what I'm saying is, one, do it because there are two things to it. One is the dye, that you should not be reacting to dye, which can be, the test dose is given, so it establishes the safety. But the other part is that how much radiation are you getting? So today there are devices where 256 lysis CT will give you such little dosage of radiation, so it's very safe. So I think from that point of view, today CT angio has found its place in the full spectrum of our diagnostic armamentarium. So it's an important tool, but must be read properly. It should not be used freely for people who have strongly positive stress tests, people who have symptoms and ECG changes, because I still see that is a little of a bit of an abuse of the modality, because people may not have a catheter-based angiography, so they will say, okay, CT karalo. So that is not correct, because if you're showing signs of the terminal signs of an ischemic event, you're showing ECG changes, you're showing you're symptomatic, then if that added up, then you are going to subject large number of people to two procedures. So there is a cost involved. You'll have to give them dye twice, and you will still, have done them a disservice. So if it's obvious that there is a problem already existing, don't go for CT. Go for a catheter based. If you want to do some screening, or actually there is a vague symptom, or you're not convinced that there is coronary artery disease, CT angio.
हेल्थ, फिटनेस और पोषण पर पाए बेस्ट डॉक्टर्स की राय सिर्फ famhealth.in पर, और हमारी YouTube पेज माय फैम हेल्थ पर सब्सक्राइब करना ना भूलें।